Welcome everybody to today's HELP webinar. I'd like to introduce you to today's speaker, Kimberly Moore. She is the Director of Healthcare Revenue Cycle Consulting at Eide Bailly and has more than 25 years of healthcare leadership experience, providing services to acute and specialty hospital and health systems, both for-profit and nonprofit, critical access hospitals, group provider practices with both single and multi-specialties, rural health clinics and FQHCs, as well as revenue cycle outsource firms. She has experience with consulting, training, business development, project management, revenue cycle leadership, patient financial services, patient access, health information management, HIT selection and conversion, and implementation, and she conducts revenue cycle improvement projects for the healthcare industry, workflow assessments, planning and execution for process improvement, and performs key performance indicator metrics management. Kimberly is a member of the Healthcare Financial Management Association, the American Academy of Professional Coders, and the Medical Group Management Association. So I will turn it over to you, Kim, to share your presentation. And it's star 2 to unmute your phone line.
Can you hear me, Leslie?
Yep, I can hear you now.
Oh, okay, perfect. All right, thank you for the introduction. I am Kimberly Moore with Eide Bailly, and it is my pleasure to present to you today something that's near and dear to my heart, and that's the financial clearance and pre-registration process for the hospitals, clinics, just about anywhere that a patient will try to access a facility. And just to kind of give you a little bit of debrief, I tend to look at this through the patient's eyes and what their needs are. And I feel like once we have established the need of the patient, it will help us to make sure that we're also protected as a facility from any risk that may be out there. So we'll get started, and if you have any questions throughout, of course, please unmute your phone and ask, and then I think we'll have some time at the end for question and answers as well. So our outline today will be talking through some financial clearance steps and sort of my take on what best practices would be for your facilities. We'll also talk a little bit about financial conversations. Although this is geared more towards financial clearance prior to the services and pre-registration, we'll also talk a little bit about the encounter and post-encounter steps that we can take to make sure that we have covered all of our bases. Reduce accounts receivable days through effective self-pay processes as well. We'll talk a little bit about that so that we can make sure that starting at the beginning, we've set the stage for our patients to understand our processes. All right. Hopefully you can see this pictorial and it's clear for you on your screen. If not, let me know because I have it also in the Word format where it's a little bit bigger. But this is sort of my vision of what a functional process might look like, and this is what we'll talk about today. So you'll see the top line, it says, the top darker blue line, 7 days prior to a patient's service. Obviously, not all of our patients are going to, number one, schedule prior to 7 days, or number two, be pre-scheduled. We have patients that come in unexpectedly, either through the emergency room or a provider calls us today and says that they want the patient to be seen today. Keeping that in mind, this would be best case scenario. And some of these topics that we'll talk about can still be placed into a more emergent type visit or urgent type visit if it doesn't come through the emergency room. And I have 3 functional areas, which one of them starts at the practice, and you'll see that indicated by a P in the first little box to your left-hand side, where it's more practice management pre-processing team. It's where our our practices in our community, whether they be owned by us or whether they be independent providers that are referring into the hospital, these are the steps or the things that can help create a better process for pre-registration and financial clearance. And it includes a liaison. So someone from our facilities at a hospital would have someone that works directly with someone in our clinics, again, whether that be owned or independent providers, where pre-certification, prior authorization, benefit verification, patient estimates can be discussed. Demographic variances can be managed. So if I have a patient that tells me their date of birth is October 20th, 1969, and someone accidentally enters it as 1968, that variance can be managed. Or those that may be a little more sinister, where they're actually red flag rules have been violated, and we've actually got someone who's pretending to be someone they're not. And then our charity screening can be discussed. So that starts as far off into the prior to the services as possible at the physician clinic, where we're really managing this more holistically and as a community versus us individually as a hospital. We also have a hospital pre-processing team where those same services are being reviewed, pre-cert, pre-auth benefits, and making sure that everything we needed as a hospital also gets taken care of. And then moving into financial advocacy. And I like the word advocacy here because we have patients that are coming into our facility that really don't understand health care. And they don't really want to be in our facility. And we need someone who's really advocating for them as well as the facility. So it becomes a sort of dual personality that someone has to have, where we're looking out for both sides. And that's financial resource coordinator, someone who's located at the hospital that really helps patients with financial assistance screening. Special account follow-up, so something that is outside of our ordinary type of account that's coming into our facility. Maybe I have an example of a young boy who was coming from another country for services rendered in one of our facilities, and the host family was the one that was bringing them to the facility. That would be considered a special account. Mom and dad aren't the ones that are responsible. Host family certainly aren't responsible. The government was and the hospital itself was helping to pay for this patient's very special services that were going to be rendered in the United States. And then financial counseling can also be a part of that team, that financial resource coordinator team. Outbound, I'm losing my voice, pardon me. Yeah, this is an allergy season, sorry about that. Outbound calls by someone sitting either in your facility or working from home or working off-site that actually makes phone calls for patients who, number one, haven't been contacted. Number two, might need special arrangements. Maybe they need additional assistance for a financial assistance application or a loan that we're trying to help them set up. And that truly becomes that outbound where it's never face-to-face with the patient. It's truly handled electronically. Pardon me again. I apologize. In-house financial counselor, that is the true face-to-face. When the patient actually arrives at your facility or comes in prior to a service to discuss financial obligations. Okay, so that kind of identifies what we're going to be talking about today in a more visual format, so that you can see sort of how best practice for pre-registration and financial clearance might look if I were to put it in a pictorial. So first, as we look at this whole pre-registration process, I've actually worked in facilities that have never really considered point-of-service collections. They feel like things need to be handled more on the back end. versus the front end. And in today's times, we're seeing more and more facilities that are kind of backtracking on that and saying, hold on a second, we really need to start educating our patients up front. And how do we do that internally? How do we get everyone's buy-in internally on why we need point of service, why we need to financially clear a patient before they come in and have services rendered? My personal experience is that if we don't bring our teams internally along to understand why it's important for us to do point of service, for us to do financial clearance prior to a patient service, our attempts to implement something of that nature will fail. Clinical teams need to be involved. Our CFO, CEO, CNO, everyone needs to be on board with us. And we can do that through creating an improved visibility for what we're doing up front, so for what our patient access team is doing. And we need to determine the value of this process, show support for this process for point of service, and do that through analyzing our current self-pay accounts receivable, number one, and how that translates into our bad debt expenses. And then number two, with what's happening today and more insured patients that I consider underinsured patients, we also need to start having conversations with those patients who look like they have insurance but truly end up being the biggest payer of the service because of deductibles or coinsurance. So we really need to make sure that we've got a way to present that information to an extended arm of the revenue cycle team. And that extended arm is our clinical, our providers, and our local providers in the community. We need to also monitor back-end denials and write-offs that might be happening due to things that are happening on the front end. So if I don't implement a point of service collection process or a point of service education process for my patient, and I don't get a prior authorization, this is the end result. In the back end, I have to write it off as a denied service for no pre-authorization. And we really need to make sure that we can track those denials or adjustments and link them back to what could have happened on the front end if we implemented a good point of service process, pre-authorization or pre-clearance process. Create a percentage of net revenue target and track them against our point of service collections. So if we have our net revenue and we know what our net revenue is, we know what percentage we should be collecting based on the patient's plan or lack of plan if they're self-pay. So we want to make sure we can track that through our system by registrar so we know what they're collecting, or financial counselor depending on who's doing your collections for you, by department. So what we find is there are sometimes offenders of getting a patient to actually stop at the registration desk. And I'll give you two examples, and not to pick on anyone, but I tend to find laboratory and X-ray or radiology as those who have patients come back without stopping at the registration desk. So make sure we're tracking it by departments as well. And then if you have multiple sites, track your point of service collections by site. Determining the actual dollars collected versus expected point of service is something that I feel is very important to measure, but can also be very difficult to measure. And so what we have to do up front is make sure that we understand what the expected point of service collection could have been and set that goal. That can be a time-consuming process if we don't have technology to back us up. And what I mean by that is if I know Blue Cross Blue Shield plan ABC, the patient has a $20 copay, I know I should have collected $20. If I didn't, then that's almost a red mark against that registrar because they weren't able to collect the $20 at the point of service. So I get down to that type of detail when I'm talking about really determining my actual versus expected point of service. If it's a percentage of my charges, of course that's determined by what I expect the charges to be versus what they end up being. So it can be kind of time-consuming and a little bit cumbersome or clunky if I don't have technology to back me up on determining what the point of service should have been. Excuse me. The HIMSS published a very detailed article regarding optimizing not only registration and technology, but also scheduling and registration process, back-end denials process. And I'm going to talk a little bit about that right here, because really this is sort of a book or Bible that I use to make sure that my clients are actually performing where they could be, where others are performing. Those that are successful have an integrated IT system where their scheduling and pre-registration functions talk to each other. In many cases, that is a centralized scheduling, pre-registration, financial clearance department. It can either be off-site or on-site, but it actually happens and the systems talk to each other. Tests are entered into a single online scheduling system. Now, where this isn't available, we can still create process around sort of disparate systems if we need to, by having, if each of our departments has our own scheduling system or we don't have it centralized, there should still be that communication where an appointment is scheduled and then gets to our pre-registration department for financial clearance prior to that patient coming in. Hospital policy for documentation. So there's a lot of documentation that we ask our patients to come up with before they come in to have services rendered. And that can be a bit overwhelming for a patient, especially if they don't understand why we're asking them for their driver's license every time they come in. They don't understand why they need a copy of the insurance card each time they see us. Where they just give it to their doctor's office. Why do we at the hospital need it now? There's also a lot of documentation that we require for financial assistance, for example. And that, all of those, we understand that because we're in this industry, but patients that are coming in that really have no idea how healthcare works may not understand it. And creating a simple, short format of explaining why we need certain documentation helps the patient to understand, and the next time they come in, they're ready to hand us their insurance card or their driver's license. Reminder calls can be a time when we can, have that conversation with the patient and talk about prior balances. This is something that I find a lot of facilities don't do during a pre-registration process. As a matter of fact, our pre-registration teams in many facilities don't have access to even look at other accounts that patient or that patient's family might have. This is an opportunity for us to open that up and begin to have conversations with our patients so that they start to understand their responsibility for the financial component of their services and our expectation of what they'll do when they come in to see us. We're also able to talk about our collection policies with our patients now prior to services ever being rendered. And then, of course, this is also an opportunity time for us to talk about clinical preparation for services that are rendered. So if we can combine those into those reminder phone calls, it makes it more effective and allows us to have less number of calls that go out to our patients if that person who's making the reminder call has the ability to talk about clinical, financial, and past balances. Uninsured patients should be directed to a financial counselor. Having that financial counselor as a part of the registration team allows us to start financial assistance applications or determining whether they qualify for Medicaid, for example, or maybe crime victims or homeowners insurance that should be, taking care of this service. Or maybe it's a COBRA plan that it's an insured patient. They don't necessarily qualify for our financial assistance, but we've determined that they're still within a COBRA time frame, and if they pay their COBRA bill, it would be much less expensive than them coming in and having services rendered and paying in full. I'll tell you from personal experience, and those of you that were on the call last week know that my daughter broke both of her wrists, and I just got the bill in the mail, and it was $22,204. Now, I'm in this industry, and I understand that my insurance is actually going to pay for it, even though I'm needing to strangle them at the moment. But those that wouldn't understand it and have no clue might panic and either not pay the bill, not call the insurance company, not reach out to a financial counselor to say, hey, what are my options? Here, I've got this bill for $22,000. What can I do? It's actually opening it up and allowing that patient to know that there is someone that is there as an advocate and is on their side. So when we look at the pre-registration and scheduling KPIs, key performance indicators, there are a couple that I want to point out. You guys can go back and look at these in more detail. If you have questions about how we might be able to get to some of these metrics, by all means, let me know. But pre-registration for scheduled patients at greater than 98%, that has been a goal that I've kind of kept in most of my facilities. If we have a scheduled patient, now keeping in mind that scheduled in this case means 7 days prior. We may not always have a patient that they may be scheduled, but they may be scheduled 24 hours before the service is being rendered. So when you're setting up this metric, make sure that you set criteria around how many days out you'd like to see something scheduled, and so that you can hold your pre-registration teams accountable where they should be and not ding them where they shouldn't be dinged. So medical necessity checking at the time of scheduling, we have that at 100%. So a lot of places will do that medical necessity checking, but it happens at registration. So the patient comes in, we know what they're being seen for, we send it through our medical necessity checker. This is maybe a little different train of thought, and we actually push it to the scheduling component. So when we actually schedule that service, we're making sure that it's medically necessary. The other things that we may not do within our facilities are really track inbound, outbound calls, how long it takes for us to answer a phone call, call abandonment rates. So if you have someone sitting on hold for 3 minutes and they drop off, that would be considered an abandoned call. We want to make sure that we're able to track this. That entails more technology. In a lot of cases, facilities will outsource sort of that self-pay component as an early out process, or they'll outsource their registration financial clearance process, so that these types of things can be guaranteed. And we know that there's certain standards that are out there for answering phone calls and making sure a patient is taken care of, and we can track that. So some of those indicators that, those KPIs we just talked about, the number of tests, phone calls per test, that was one of our indicators back on our KPI page. And I talked a little bit about this, that each time we call a patient, some patients feel like it's an intrusion. And I know for myself, I've got several phone calls for a single appointment, and I feel like my facility that I go to may not know, right hand may not know what the left hand is doing. And that's not the impression we want to create for our patients. So internally, if we can come up with a process that says 1 or 2 people will be calling a patient to talk about a service that's been pre-scheduled, allows that patient to not, number one, have many phone calls coming through, and number two, we can have a conversation with that patient. Say, hey, you're scheduling this today. You can expect to receive a phone call from our financial counselor as well as our clinical manager or whoever it might be that's making that second phone call. That sets an expectation for our patient so that they know that that phone call is coming. And then if they don't receive it, that you need to make sure that they have a way to get back in touch with you. It puts a little bit of responsibility back on that patient as well that says, hey, you should be expecting a phone call within 2 days. If you don't receive it, make sure you call us back. It'll be very important for us to financially clear this before you come in for services, to make sure your insurance is going to cover this. So it kind of puts a little bit of responsibility back on that patient as well. And then there are some other ideas on things we should be tracking, which might include those patients that we need to reschedule because we didn't get an authorization. We should be tracking that so that we can do process improvement for our registration team so we can get to best practice. We should also monitor the number of patients that reschedule or cancel. One of the skill sets that our registration and scheduling teams need is to really understand the service that the patient is asking for, to understand what is going to be provided. And that comes through education, and our patient access directors, financial counselor directors should be making sure that the team understands the services to the best of their ability so that when we're scheduling something, we can have good conversations with the patient about what to expect financially and clinically when they come in to see us. So optimizing our patient access areas is also another area that we'll kind of talk through. And it still relates very much with that pre-registration and clearance process. If we can integrate our financial counselors with our registration, in a lot of places I see financial counseling reporting through the business office and really spending a lot of their time with patients that have already had services rendered. That's number one. And then I also see financial counselors that do spend a lot of time with truly just uninsured patients, where we need to change that shift a little bit and make sure that they're talking with patients. And my recommendation is any non-government patients, so not Medicare, not necessarily Medicaid patients, not VA patients, but truly those patients that are non-governmental, that have an insurance that we will be billing either through a contract that we have with that payer or a truly individual insurance. And changing that train of thought for our financial counselors. Now that might mean for you might have one financial counselor or two financial counselors on staff. It may mean shifting the resource just a little bit from back end to front end and taking some of your existing staff and educating them on how to become financial counselors and how to have those conversations with patients. The red flag rules is also something that we want to kind of talk about a little bit here. We ask patients right now for their ID, or at least I hope you do, on every time the patient comes in, so that we can ensure that that's truly the patient that's having the services rendered. Another piece of information that we might start to ask for patients during this financial clearance process would be their credit card, and we'll talk a little bit more about credit card on file again at the end of this presentation. But so when we're registering a patient, there are a few things we want to ask them to bring: their insurance card, and if they're not insured, financial statements, so we can start that financial assistance process, have them fill out applications, their ID, and now their credit card, if it's someone that fits into that category. To be able to optimize patient access, we also want to have an IT system that allows us to report on multiple medical records so that we're keeping our MPI under control. We want to make sure that duplications are next to none. first, really, if we can educate our team that it's not just about us not wanting multiple records on file for Kimberly Moore, it's really about Kimberly Moore's safety. Because if I have multiple records for Kim and all of her records aren't combined, there could be an event that causes me to not be safe when I'm in the facility, as well as, the financial impacts. So we want to make sure that we can improve the accuracy of our estimates as well. So that might be, you might all be shaking your heads at this time. I'm not sure. That's probably one of my biggest challenges, is to get a truly good estimate for a patient and feel really confident about that estimate that I'm giving that patient. It's challenging because we have insurance contracts that pay us differently. Patients have coverage that's different based on their group plan or what they selected for coverage. We don't always know exactly what's going to happen once they pass across that clinical veil. And so we're not always confident about what we're asking our patients to pay. So the recommendation there is that you, to the best of your ability, either have IT that allows you to pull that data together for you. And there are some pretty slick IT programs out there that give me about 95% confidence that what I'm giving them is true. But also maybe setting up a process that says, for this type of service, we're going to require the patient to pay a percentage of that, or what I might call a deposit, although it's not really a deposit towards a service. It's really towards their out-of-pocket. So keeping those things in mind, we'll move on to what some of those KPIs might look like. So the percentage of claims on hold because of registration errors, we want that to be very minimal, 1/16 of a day in revenue. So as you can see, there's not a lot of tolerance for those things that are registration errors that are on hold. Track the number of statements that are returned through return mail, and that should be less than 5% of the statements we send out should come back to us. We want to make sure that when our patients come in, we've already had them pre-register. We have asked them for a lot of data. We've asked them to provide us over the phone and take their time to do that. Let's not make them recreate it when they come into our facility and have them, give us all that information again. So that time that we're spending with our patient is value time. It's discussing financial options. It's having them sign compliance paperwork. And let's not have them wait to be registered. In fact, there are many facilities that are going to a kiosk now, where if a patient truly is financially cleared prior to a service being rendered, they can walk in like they do at the airport and do a kiosk and actually not have to see someone if they don't choose to. Now, a lot of facilities kind of push back and say, yes, but patients want to talk to us, or we need a signature, and in those cases, yes, the patient can stop at a registration desk. But you would be surprised at some of the focus groups that I personally have conducted, where our older generation loves the idea of a kiosk. Strangely, I think that I thought differently. I thought it was the opposite. I figured our older generation may not want a kiosk. But ironically, they're the ones that sort of voted for it. They're used to it. They use an ATM. They go to they fly. They use a kiosk at the airports. It's probably more my generation. I'm 44, so I'm the one. I don't want to have to use a kiosk. I want to talk to somebody. I want to touch and feel that process. I don't necessarily want to stand at a kiosk. So do some focus groups with your community to see how they might want to be engaged. ABNs, we have 100% as one of our metrics at Daily. We want to make sure that ABNs are obtained when they're needed. This particular study and KPI shows patient access doing those ABNs. Make sure that that's blended, because an ABN is something that obviously, if it's clinically needed, but the insurance or Medicare may not cover it, doesn't mean that it's not clinically indicated. And so sometimes it's easier for a clinical person to have that conversation with the patient versus your registrar who may not understand the clinical implications of the test that is being rendered or requested. So make sure that when you are collecting this data, it doesn't sit on someone's desk. As we start to monitor these KPIs, let's be vocal about them. Whether good or bad, let's be vocal and let's make sure that we're telling people either what the improvement is or what our plan is to improve and how each department can help us to improve so that we can always create quality upstream. So that it becomes very important to talk about the negatives and the positives so that we're being very transparent to our own internal customers, meaning the other departments in our facility. During this entire process, we should be having that patient balance in our thoughts, and whether it be a patient balance that they are about to incur or one that they've already incurred and they're coming back to the facility again. Make sure that we're collecting and discussing those unpaid accounts. Use a holistic approach to our patients that are coming in. Let's talk to them also about family balances that we may be able to find resources. A single account may not qualify them for our financial assistance plan, but they may have had several family members in some type of catastrophic issue that might qualify them for some assistance, whether it be from the state or from our own facilities. Internally, what we want to do is make sure that we're looking at the entire account for high dollars, so that those, if there are high dollars, there has to be an approval process internally to do adjustments or to do write-offs. And then track our compliance, our staff's compliance with our policies to make sure that we're always looking at process improvement. So we're keeping that patient informed and with the best information that we have available to us today. All right, so now we'll move a little bit into scheduling to talk a little bit deeper in, regarding scheduling. Before you get started, take an inventory of all of the routes that a patient or provider's office has that they could secure a visit with your facility. The more areas that someone can schedule, the easier it is to find mistakes in the process. Centralized scheduling allows us to have a single group of people that has access to an entire scheduling base. And we make sure that there's consistency in what's being verbally delivered to whoever's scheduling an appointment with our facility. And we make sure from a compliance perspective that all of our T's are crossed and our I's are dotted from a compliance perspective. So although many of you may not be able to centralize your scheduling, it's a thought that we need to keep in mind, even if we have multiple areas for someone to make an appointment. Each of those people that are actually scheduling an appointment need to understand lead times, for example, for certain procedures that we'll do. Financial implications if a patient's calling to schedule if they don't have insurance. Make sure that those conversations are being had at scheduling. Make sure that data is being gathered, and if there are any deficiencies in the data, make sure that we have a process in place to capture those deficiencies. I'll talk a little bit more about that in just a minute. And then having scheduling policy and procedures so that everyone understands what's required. When we talk about those deficiencies in data, one of the areas, when we're doing scheduling, we tend to want to gather as little data as possible so that we can get that patient's clinical components taken care of first. And that makes complete sense, that we want to make sure that we're taking care of the patient's clinical needs. And once we've taken care of the clinical needs and we've found an appointment for them, we've actually assisted that patient or that provider with finding an open appointment. Now it's time for us to ask that favor back. Okay, so we're done with scheduling. I need to now talk with you about the financial component. So is there an insurance you'd like for us to bill? And that can happen at scheduling. It doesn't mean that our scheduler has to be the one collecting insurance data. What it means is that our scheduler should be trained to do soft transfers to a financial counselor, financial clearance, or pre-registration department. And that soft transfer would include staying on the telephone and getting that patient to someone to actually talk to. If there's not someone available during that transfer time, making sure that the patient understands the expectation that they'll get another phone call back from your pre-registration department. And if they do not, they should call back in, because it's very important to get the financial clearance component. So it's about having the right conversations at the right time and making sure that the team understands, everyone on the team understands the implication if we don't get the right data. So when it is the patient calling, because we know from time to time it's the patient calling, and from time to time it's the provider's office calling us to schedule appointments. So we need to make sure we've got a couple of different scripting tools or ways to be able to have that conversation with our patients. If it is the patient calling, we want to make sure that we're asking them the right questions about their insurance, their coverage, and if they don't have coverage, getting them to the right person. If they don't have their card handy, make sure that they understand your expectation of them getting that card information back to you, whether that be through a phone call from you to them or them calling you back. A successful facility that I've worked with in the past had a specific pre-registration or registration financial counselor or financial advocate for a patient. And that financial advocate followed that patient through the entire pre-encounter, encounter, and then component of the post-encounter. So that I knew that I could call Susie Smith no matter what it was. She was the one that I talked to. And if I left a message on her voicemail, I knew she would be the one getting back to me. So I didn't have to repeat myself again. One of the issues that we find is that finances are not something that patients really love to talk about. That's no news to any of you on the call, I'm sure, that patients, it's an uncomfortable thing. And so if I have to repeat myself as a patient, it becomes very uncomfortable, and I will start to resist making phone calls if I have to repeat myself each time I call. So having a dedicated person tends to make that conversation a little easier. And if it's the referring provider that's calling you, ask them to fax a copy of the demographic and insurance card. Have lunch and learn with your provider so they understand why it's so important. Give them, you're feeding them and giving them information on the things that you might need. Have brochures in their facility so that they, if someone asks a question about how the hospital bills, you've got brochures there for them. But at least get the basic information that you'll need to contact that patient. And then keep them informed. Keep them, meaning your providers as well as your patients, all of your customers in a sense, keep them informed. Make sure that you're explaining things verbally and in a written format. And if you were on the call last week, this is something you'll see probably in most of my presentations. It's very important to be consistent and making sure that we have a lot of different ways for people to learn what it is that you need, because people learn in different ways, or they hear you in different ways. So financial clearance pre-encounter, it's best if we could do it 7 days prior, right? At least 48 hours in advance. You're going to have those patients that come in 24 hours in advance. The process still needs to take place. We still need to verify benefits. We still need to make sure that we're checking that patient to make sure they're really who they say they are. Are there prior authorization requirements? And if there are prior authorization requirements and we don't have time to get that prior authorization, what's your policy? Do you turn the patient away and have them come back when you're able to get that authorization? Do you have them sign a waiver stating that we weren't able to obtain that prior authorization? Those are things that you need to think about and talk about internally to make sure that you're covered. So financial conversations, both inpatient and outpatient, in your clinics, in your emergency room, make sure that you're telling them, everyone that's going to be involved in your episode of care, so they understand that they're going to get a bill from anesthesia, surgery center, the surgeon, the pharmacy, possibly. There's going to be a lot of different people that are inundating them with bills, and that you have a resource available for them if they need help. Make sure that you're asking the patients if they're interested in learning more about your financial assistance process or payment options. It kind of puts that responsibility back on them, and you're not coming in at them, kind of at them, instead you're asking. And then provide them with information regarding your policies and give them that phone number for additional questions if needed. All right, and this kind of same thing we've been talking about, but really making sure that you have, that everyone that's involved in this process understands all of the options that you have available for a patient. They don't have to be the one to initiate those options, but that they understand the options and who the right person is that can help that patient when they come in. So you can take care of your patient and protect your financial risk, if you will. Concurrent conversations, that really is, we do a lot of work, pre-work, great, but we also have those patients that come in that we need to concurrently be speaking with them. Maybe they're coming in for a service, and now we're suddenly going to add an MRI or a CT scan onto that service that's being rendered. We need to make sure we're having those concurrent conversations with our patients as well. That will require internal communication, where your clinical team is feeling very comfortable with your financial counseling teams, so that everyone knows that service is being added on, so that we make sure we protect ourselves. A little bit about emergency department that I just want to talk about. Obviously, we need to make sure we're complying with EMTALA. And if a patient presents, we need to make sure that they are clinically cleared first. And so if we have an emergent patient and they truly are an emergency, we want to make sure we're having financial conversations with them at discharge versus while the doctor's in there, sewing them back up. That would not be appropriate. But our emergency patients still require financial counseling, and maybe more so even than our pre-scheduled patients. It's a place where it becomes a very high-dollar service in a lot of cases, and it's something that was absolutely not planned. So they're not prepared financially to take care of this emergency visit. So we need to make sure that we don't ignore those and let them get into our business office and let the process happen, building insurance, whatever we might need to do, as close to the discharge as possible. Meaning I would love to see it at discharge. If it doesn't happen at discharge, it needs to be within 1 to 3 business days of that service, of that discharge. So we're having a conversation with that patient to start financial paperwork, to start Medicaid applications, things that require very timely response. Non-emergent, though, if a patient is considered to be non-emergent after clinical clearance, financial counselor should be having a conversation with that patient to try to get them to the right place for that service. And maybe it means that they're going to continue on in your emergency room. In that instance, how is the carrier going to cover that since it's non-emergent now? How are they going to plan to pay for that? Are you going to ask for them to pay a deposit for services being rendered past that triage? Financial conversation needs to happen at that time. And that's also going to involve your clinical team to say, hey, this is non-emergent. It's been, cleared as a non-emergency. It's urgent, but it's not emergent any longer. To have those conversations with your patients before continuing on. And then post-encounter, again, 1 to 3 business days after a discharge, we need to make sure we're having some type of conversation and follow up on all of their promises, whether it's to pay or to fill out more paperwork. With the Affordable Care Act, we may need to consider sort of reworking our workflows to include a very robust process to help patients either if your state is expanding Medicaid, get on Medicaid, or if not, to help them get onto the exchange or marketplace to help them find coverage. Becoming their advocate becomes very important. For your uninsured patients, conversations can be tough because we have patients that are coming into our facility that obviously are ill or something's not quite right with them. They are seeking services because they aren't feeling well. But financial conversations need to be had, and we need to make sure that we are looking at our patients holistically and sort of stratifying those patients and saying, okay, these patients truly will qualify for financial assistance. These patients are probably going to end up in bad debt because they won't pay their bill. We know this. But a recent study showed that 31% of our bad debts that we're showing as a write-off could have qualified for a financial assistance program. So a couple of things. If you're a nonprofit organization, financial assistance will show your community benefits. And we want to make sure that you're following 501R requirements, the new tax requirements under the ACA. So really making sure that you're categorizing those patients in the proper place. It may not have helped you in your margin and your bottom line, but at least you're getting those adjustments in that uncovered or that non-paid service, uncompensated care in the right bucket, whether it's charity or bad debt. So that might help. There are some processes out there and products that are out there that help us to do self-pay risk segmentation. And basically what that is a propensity to pay kind of score. If I have a self-pay AR, what component of that AR truly should be left in-house that I'm going to manage myself? What can I send to an outsourced vendor, for example, to minimize my human resource requirements and costs? But it allows you to evaluate, get a true valuation of what we expect to collect from our self-pay dollars. And this is kind of what it might look like from a visual perspective. We have patients that are very low risk and high propensity to pay. So I don't need to spend a lot of human resource and time on those patients. There are patients that are a very low propensity to pay, low dollar amounts. So should I spend a lot of time on those patients because they're not going to pay and there's not much dollars to collect even if they did pay? So it really kind of gives you that scope of where we should be putting our human resource time. And this is really after the fact, but this type of scrubbing, if you will, should be happening at registration, pre-registration, sort of in that mid-range when we're doing the billing component, and then prior to sending someone off to a collection agency. And then securing your AR